Hello, everyone, and thank you for joining us for what I hope will be a very interesting and informative discussion today around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University in beautiful downtown Brisbane, and today I'm delighted to be joined by Dr. Mark Russell, who's a clinical research fellow at the Centre for Rheumatic Diseases, King's College in London. He's still reeling from the cricket where the Australians are 2-0 up in the Ashes, but we'll talk about that later. Thank you for joining me today, Mark, to discuss your paper that was published in Annals of Rheumatic Diseases. The paper is available with slides and things on the CSF website. We'll talk about that later. This paper looks at a very important issue, and that, following oral surveillance, is the question of malignancy and the incidence of malignancy with JAK inhibition compared to placebo, TNF inhibitors and methotrexate, and it comes from a meta-analysis across disease indications. So before we start, Mark, can you tell us a little bit about yourself, where you work and what your interests are?
So thank you very much. Thank you for having me on today. So I'm Mark Russell. I'm an NIHR doctoral fellow and rheumatology, especially registrar at King's College London. So my background is looking primarily at big data across different fields. So both pharmacovigilance, so for example, what we looked at here for JAK inhibition, also looking at how you improve care for people with inflammatory arthritis and particularly crystal arthritis. So we've got links at the centre with the National Early Inflammatory Arthritis Audit, for example. But this was a particular area of interest for both myself and my colleague, Dr. Galloway. And so we wanted to look at all the body of evidence and try and see whether the results of oral surveillance were borne out when we looked across multiple disease indications.
Excellent. And I'm not sure that you can answer, but can you get a feel for what's happened to the JAK market since oral surveillance? Has there been a big change in prescribing?
So I think it probably varies somewhat, well, certainly by country, but somewhat even within region, within the country. I mean, in our sort of local region, there's certainly more caution following the EMA, the FDA and the MHRA warnings. I think you certainly have to be more cautious when discussing with patients, making sure you've been through the key findings of oral surveillance and other studies as well. I think that you now have to provide more justification as to why, say, an alternative mode of action, targeted therapy or biologic wouldn't necessarily be appropriate, or why JAK inhibition is the correct treatment. So I think whereas before we were increasingly prescribing, in many cases in the UK is second line following TNF, that may be the case in some patients, but now I think there's a lot more requirement for justification following on from the data.
And do you think that when we go through that EMA restriction, over 65, lifelong smokers or current smokers, and then there's nebulous at risk of malignancy? I mean, what does that really mean? We're all at risk of malignancy.
Indeed.
And does that mean colonic polyps? Does that mean Barrett's esophagus? Does that mean whatever? That's why your paper is so important. Yeah. So can you tell us a little bit, for those who aren't statistically minded, how one does a network meta-analysis and pairwise whatever else that you do?
Yeah, absolutely. So the first step is to get all the data together. So we did a systematic literature search of JAK inhibition across all disease, the majority of licensed disease indications, and not just rheumatoid, but psoriatic arthritis, psoriasis, inflammatory bowel disease, even atopic dermatitis, to try and make sure we had as much data available, bearing in mind that malignancies are rare events. And then once you have that data and you've extracted it, you then need to pull the results across the different arms. So for a pairwise meta-analysis, you look at only data where there are direct comparisons. So say, for example, JAK inhibition versus placebo or JAK versus methotrexate. You use your preferred statistical package, and it pulls the incident rates, comparing those sort of direct trials, and gives you a pooled incident rate ratio that gives you an idea of sort of an effect size for malignancy within that. Now, the benefit of network meta-analysis is we don't, for example, have direct sort of from those particular comparisons of other different groups. And this allows you with network and meta-analysis to do indirect comparisons based on studies that had, for example, JAK and methotrexate, JAK and placebo. And so you get an indication of, and this was particularly helpful for ours, where we wanted to see of the included studies, when you compare TNF and placebo, was there any difference in malignancy incidence? Because by having that information, you can then sort of at least hypothesize as to why we saw an increased incidence of malignancy with JAK versus TNF. And so that is why network meta-analysis in particular is very helpful.
So you had 62 eligible RCTs and 16 long-term extensions. You had something like 82,500 person years of exposure to the JAK, but only 3,000 person years to placebo, 8,000 to TNF, and 1,000 to methotrexate. Now, if you have that difference in person years of exposure, is it going to make a bias for or against one group or the other?
So that's a really good point. And this is always a problem when you're meta-analyzing RCT data, where often, particularly the placebo arms, are both shorter and sort of less abundant in terms of person years of exposure. I think the bigger issue actually, as well as the amount of sort of person years of follow-up, is length of follow-up. So for placebo arms, the duration of follow-up, or the mean duration, was around 20 weeks, or the median duration, whereas for JAK inhibition in the meta-analysis, it was about 120 weeks. And because malignancies are long latency events and take time to emerge, that may favor the shorter duration. So in many cases, we were somewhat concerned through a potential bias that we may see a signal of harm with JAK inhibition compared with placebo for that reason alone. But actually, somewhat reassuringly, that was one of the primary reasons we separated out analyses of just RCT data, and then also including the long-term extension data, where you might expect more events to accumulate with JAK inhibition. But when you look at those comparisons of JAK versus placebo in both those two groups, there was no significant difference. So that suggests that at least that potential bias probably didn't have a big clinically meaningful impact on it. But you're absolutely right, that is a big limitation when looking at RCT data.
And what about dose? Because in oral surveillance, they lump the 5 BD with the 10 BD, a dose we don't use. It's used in IBD, but we don't use it. Now, is that going to bias? No, can you clarify when you do a meta-analysis and look at the smaller dose, the higher dose, same with filgotinib, same with baricitinib?
Yeah, and that's another thing. And, you know, increasingly, well, during the study, 10 BD was noted to be the dose of potential harm in particular. And so we wanted to try and account for that. So we did a sensitivity analysis whereby we excluded higher doses. We specifically excluded 10 milligrams twice daily for tofacitinib, but also the higher dose of upadacitinib, so 30 milligrams once daily, where again, there had been some concern of a potential signal. It didn't make any difference to our primary results. So it suggests that, you know, the problem is you're then getting down to smaller numbers of events, but I think it's an important sensitivity analysis to do, and it didn't change our primary findings.
Okay, that sounds good. And the other thing is, we talked about dosage, we talked about duration on drug. I was thinking about background expected rate in an RA population to give you an anchor to compare the numbers with. For example, TNF might have less than JAKs, but both might have less than RA untreated.
That's a really good question. So I have to say, to be entirely honest, I don't know what the absolute incidence rate in a background RA population is. What I can say, certainly, and I think this is an important message that we try to emphasize in the paper, is that the absolute incidence rate, even across all the different arms, was low, relatively low. So around 1 or just over events per 100 person years of exposure. And you're right, you know, particularly in oral surveillance, it was enriched for a population who will be certainly at risk of malignancy. We didn't just limit our analyses to that particular population. But again, I think when you're absolutely right, when we're having discussions with patients, it's very easy to sort of focus a lot on the relative risk, but actually the absolute incidence rate was modest across the different arms.
And I think that's pretty critical because we've seen publications from Melbourne that methotrexate by itself triples the background rate of non-melanoma skin cancer. We've seen Humira studies published that adalimumab increases background rate of non-melanoma skin cancer. We saw a signal with TOFA previously, and that was written into the consensus use of JAK inhibitors, the important point of a signal for non-melanoma skin cancer. Have you taken a good look at oral surveillance? Because even though the event rates are very low, there was more melanoma on the TNF side than the TOFA side. There was more prostate cancer on the TNF side than the TOFA side, but a clear difference in non-melanoma skin cancer, 13-2, TOFA versus the TNF. So tell us what the characteristics of your study and some of the results of what you found, and in particular, the breakup of malignancies, if you take skin cancer out, if you leave it in, and melanoma as well as non-melanoma skin cancer.
Yeah, and this was something we really wanted to look at because of that, the particular concern about non-melanoma skin cancer. So whereas our primary finding was bringing all cancers together, we did separate analyses looking at all solid organ cancers, or all cancers excluding NMSC, and then non-melanoma skin cancers only. Now, the primary findings were similar whether you excluded or included those. But I would say, if you look at the numbers in the paper, it seemed like the signal for harm was greater with non-melanoma skin cancers. So particularly when we're looking at JAK versus TNF, the incident rate ratios were towards greater harm for non-melanoma skin cancers than they were for if you excluded those from your analyses. And I think, there's been similar data. So there's a great study published recently of registry data, the ARTIST registry from Sweden, that showed a similar thing. At least that was predominantly baricitinib in their registry. But again, it was the signal of potential harm was for non-melanoma skin cancers rather than solid organ tumors. The other interesting question always is with hematological cancers and lymphoma. This is something we did try and meta-analyze separately, but because there are very few events, it is difficult to do so, and you would end up with very wide confidence intervals. And that's the same true of individual solid organ cancers. So ideally, and maybe in years to come, we'll be able to pick out, is there a particular solid organ malignancy that incidence rate that's different? But at present, the confidence intervals are too wide, and also many studies still don't adequately break down by cancer type, or they're sort of heterogeneous in how they do that, which makes it very difficult to pull the results.
Can you give us a feel? Like, we look for relative risk differences, and they look like 50% and 30% and 25%. But what's the absolute risk difference? So if the risk of melanoma, I live in the skin cancer capital of the world, so we're very attuned to melanoma and non-melanoma skin cancer, and all our patients get formal skin checks at least once a year, and the GP is all over it regularly. So just give us a feel for the absolute difference. If it's 1 in 100 risk of non-melanoma skin cancer, and TOFA increases it, or JAKs increase it to 1.35 in 100, no one's going to get too upset. But if it's 25 going to 45 or something, then people justifiably get upset. So can you give us a feel for the absolute risk? So not melanoma and melanoma, and even those solid cancers.
Yeah, so that's a good point. So I can't give you the exact. I could certainly easily calculate it, but haven't at this way. But we did briefly look at it, and if I remember correctly, and I wouldn't necessarily quote me on this, it was, if I remember correctly, the number needed to harm would be about 1 in 200, but I would have to double check that, and don't quote me necessarily on that. But I think that's the point. Although the relative risk difference was could be seen, it was 1.5 for, say, JAK versus TNF. The absolute event difference will be relatively small. But again, this is without long-term follow-up data. And often the potential concern is with younger people, when we're treating increasingly younger people with active rheumatoid, let's say with JAK inhibition, we often need that longer term follow-up data to help really inform that. But I think that's where registry data will be very important. So I'll need to calculate that. But yes, I suspect it's relatively small in terms of absolute increase.
Only because the number of events is so low, it makes it important. And also that your conclusion, which we'll come to in a second, if the rheumo just looks at the headline and doesn't read the rest, they say JAKs cause cancer, end of story, rather than JAKs increase the risk of non-melanoma skin cancer, end of story. So let's just clarify that a little. Everyone's very concerned about lymphomas. Did you see any lymphoma signal with the JAKs compared to the other drugs?
So we looked at that. We can't really draw because the events were too rare. So we do present the absolute incident rates, but they are low across all different arms. And so a comparison between them is the confidence intervals are too wide. But I agree exactly with what you say there. If you just look at the headline first sentence to conclusion, it looks concerning. I think when you look at the supporting data and that actually for JAK versus placebo and JAK versus methotrexate, there was no significant difference in malignancy risk. That's somewhat reassuring. And then additionally, as we've said, the absolute incident rate of malignancy is low across all groups. And so I think that's important context. And of course, this was driven, the primary result of JAK versus TNF potentially causing harm is driven by one large study. And that was enriched for the event of interest. When you excluded that from the analysis, there was a potential sort of trend towards harm still, but that was no longer statistically significant. And I think that's an important thing to take as well, is that this is driven primarily, at least the JAK versus TNF comparison, by a very large post-market surveillance study that had a different aim than all the other included studies.
Okay. And did you see any difference between JAKs?
So we looked at that. So we pairwise meta-analyzed them individually, and we saw no statistically significant difference between JAK and placebo, individual JAKs and placebo, when analyzing them separately. And so the answer to that would be no. But again, these are rare events and you had quite wide confidence intervals, so you would need more data to be absolutely certain of that. But at least in the data we had, we didn't see that one particular JAK was more harmful than another compared with placebo.
So just reassure me a little about the other solid cancers, breast and prostate, and then melanoma itself.
So we don't have the data, sufficiently granular data to analyze by cancer type. So that was something we collected data on, but either studies, not all studies reported or broke them down sufficiently, or there was different ways in which they did, despite them trying to homogenize that through things like clinicaltrials.gov. But also the number of events, even for the bigger cancer types, were relatively rare, and so it made it difficult to do that.
Okay, and anything else from your results that you want to report on to help the clinician with the patient sitting in front of them?
So I think my sort of a key take-home thing would be that, one way of interpreting this is that you look at the headline and you think, well, JAK is harmful versus TNF. I think probably our take-home and what we hypothesized is that it's possibly more likely that the effect of JAK on malignancy is neutral, whereas at least with the data that we included for TNF versus placebo, it was potentially protective. So it's more that it's perhaps less protective than TNF in terms of malignancy in these data. So I think that's important. I mean, we can't draw very firm conclusions on that, and only future data will show. But I think from an interest perspective, so there was a similar picture with TNFs in the early years. When they first came out, there was a big concern about the risk of malignancy with early meta-analyses. And then as more data accumulates, particularly observational data, it sort of shifted the other way. And in recent years, there have been some studies, particularly from East Asia, showing that the risk of malignancy is lower with TNF than with placebo. And it may be every time that we see a similar thing, but until we have that registry data, it's hard to know. But I think the bottom line is they are relatively rare events. It's very important to discuss that and say that there are, obviously these warnings, but at least on the basis of this, it didn't show any new signal of harm. And in some ways, it was quite reassuring that there didn't appear to be a signal versus methotrexate or placebo.
So we have to remember that no patient with a history of malignancy within 10 years ever gets into a clinical trial.
Yeah.
the highest risk probably aren't in. You probably won't be able to identify the number of people who these people develop a cancer whilst in the study, and they would have dropped out mainly, or some continued on drug anyway. Especially the melanoma skin cancer would have continued on drug, I suppose.
Yeah, so that's an interesting point. So we can't say whether they dropped out during study necessarily, but what we can do, you're absolutely right, that's an important thing from a methodological perspective, is that either people will have been screened, people who had symptoms in keeping with malignancy at trial entry will have been screened out, and then the cancers develop over time. And that again favors shorter duration study arms. But what we did do is another analysis where we excluded cancers that occurred within 6 months of treatment allocation, again to account for a potential sort of induction where people may have had cancer at the time of study entry and then developed it during that process. But even when we excluded those cancers that occurred within the first 6 months, it didn't change our findings. So this is not necessarily just to say that there was a difference in people who had cancer at entry. These tended to occur over time as well. And even when we excluded early cancers, it didn't make any difference to our primary findings.
Because there have been a couple of registry studies, the STAR-RA, Cora-Vitas, and they couldn't show a difference in malignancy rates with TOFA in particular. And again, just remind me, there was no dose effect that you saw, as oral surveillance also did not see a dose effect for malignancy, and the number needed to treat were a few hundred for one event over a year. So is that fair? No dose effect to show an increased risk?
Not when we, yeah. So when we excluded the higher doses, we didn't see it dramatically change our event rates or our effect sizes. So at least in our analysis, we didn't see that. I think, as I mentioned before, the new registry data, so emerging registry data from Sweden, that was on baricitinib, that was again, so I can't remember what doses they include within that, but that again, there was a signal arm potentially, for non-melanoma skin cancers. But there was one interesting analysis that looked at safety of upadacitinib in sort of an integrated safety analysis, so looking across all their trial program. And with that, the potential signal of harm was with upadacitinib 30 milligrams, hence why we made the decision to exclude that. But again, when we did exclude it, it didn't appear to change our events. But we have to bear in mind that when you start excluding, the number of events become even smaller. So there's a slight caveat with that, but at least in our analysis, it didn't change what we found.
And can you postulate any mechanism of action why JAK might increase non-melanoma skin cancer or solid or other cancers in particular?
Yeah, so that is something we certainly looked into. So probably the most convincing mechanism that I found, having looked through things, was an effect on NK cell maturation, also tumor lysis capacity as well. And there's been both, primarily in vitro studies that looked at that, and that also showed that there did appear to be a differential JAK effect on that. So it seemed that in vitro, tofacitinib had a greater impact on NK cell function, which is important for sort of anti-tumor surveillance. And so that mechanistically sort of seems quite nice in explanation. But again, because it's so complex in terms of JAK-STAT signaling, that would be very simplistic just to say that it was just one thing causing that. So I think it's more likely to be multiple different pathways, some pro-inflammatory, so pro-malignancy, some sort of against malignancy. And, again, it's important. We know that active RA or active inflammation can promote cancer. So if we are adequately treating that through efficacious treatment such as JAK inhibition, that is likely to drive down the risk of certain malignancies, particularly lymphoma. And so there are likely to be multiple things pulling in different directions. But NK cell sort of inhibition was one thing that particularly stood out when we looked through the literature.
And that's important because I think the JAKs have differential effects on NK cells. So
exactly,
both are a little bit more likely to knock NK cell numbers, and the more selective or preferred JAK1 inhibitors maybe not so much effect on NK cells. So that might turn out to be quite critical. So I was thinking about something else. To wrap it up, to summarize, the event rates are very low. We should have a think about the background rate. we should understand that there's no differences between JAKs and methotrexate, JAKs and placebo for all malignancies, even including non-melanoma. And you showed a difference, JAKs and TNFs, and that difference was really driven by non-melanoma skin cancer. Yeah, anything else that you'd like to take as a take-home message for the practicing clinician to think about? Oh, that's what I was going to ask you. Would you have seen if a combination JAK plus methotrexate versus JAK alone had any difference in risk?
So we included studies that did have background stable methotrexate within that. The usual comparison, of course, would be JAK plus methotrexate versus methotrexate alone, and we included those studies. The other ones we included obviously were JAK versus methotrexate monotherapy, so the earlier studies, and they were all included within it, and they didn't change our sort of primary findings. But you're right, when we're very hard to pick out. I think that is a key take on this. This shows methodologically how difficult it is to separate people who've had exposure to previous targeted synthetics or biologics or conventional DMARDs, people who are at different stages in their disease, which might be why over time we are seeing perhaps a protective effect of TNF now that we are treating people more aggressively and they haven't had multiple lines of therapy over many years, whereas in the earlier studies, this used to be sort of last ditch therapy, and we're treating people better. And so I think that methodology makes it very challenging to separate out, as you say, difference between different drugs. But certainly in ours, when we looked at say, JAK versus methotrexate or JAK versus placebo, and that would include people who had stable background methotrexate, it didn't change that primary finding of no significantly different risk of malignancy between those two groups.
And where are you going to take this research in the future? What's the next step to try and help the clinician?
So the key, I think, is real world data. And what we're hoping to do, and we're in the process of starting to look at that, is to look at some of our, in England at least, we're fortunate to have some very big real world data sets. So data sets such as Open Safety, where you've got up to 99% of the England's population within that. And I think you need that sort of number of patients to start seeing those differences in rare events. The key will obviously be duration of follow-up too. And I think over the next year or two, we're hoping to look at particular malignancy event rates, VTE and MACE event rates with JAK inhibitors and other biologics. So that's what we're hoping to look at soon. And only then, I think, can you really tease out whether there's a particular cancer or whether actually there is no effective JAK on malignancy.
And to finish, do you think the EMA was correct to say that anyone at risk of cancer should not take a JAK? Or should that really have been people with recurrent non-melanoma skin cancer should be careful?
Yeah, I think because there was a signal of harm seen also when you excluded non-melanoma skin cancers, it would be very hard for them not to do an across the board, across the cancers, let's say, warning. I think they always err on the side of extreme caution, hence why they've done it. I do think it makes our job somewhat more difficult in that we have such an efficacious class of drugs that we were using very frequently, and now we're certainly it can't do anything but make you somewhat more cautious. So I think it makes our job harder, but they often, it's not unexpected that they've erred on the side of extreme caution, I think. But hopefully with more data, we can refine that, whether it's a class effect, whether it's individual drug, remains to be seen.
So very important, and keep working away to help clarify this very important issue, because whether we like it or not, JAKs are here to stay. Yeah. Last time I checked clinicaltrials.gov, there was 270 trials going on for JAKs oral, JAKs intranasal, JAKs inhaled, JAKs topical, across every different disease that you can. And because I live in the Asia Pacific, where people can't afford more than 4 weeks of any treatment, there are now 4 generic TOFAs, 2 generic Barrys, 2 generic UPAs. And when treatment is cheap, you can treat people who have RA that can't afford treatment. So we can't afford to let this group of drugs disappear. So we really have to learn how to use them very safely. And the more we can learn about risk and benefit, the better for everybody. So thank you very much for your time, Mark. Greatly appreciated.
Thank you very much.
I'd like to know more about this paper and others uploaded to the CSF website this month. You can get detailed slide sets that are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on Spotify, iTunes, or wherever you get your podcast media. We're very keen for you to have some feedback. Send us some feedback. Let us know what you think. And we greatly appreciate your time. Thanks very much, Mark.
Thank you very much. Thanks for having me on.
All the best. I think you're doing well in heading league.
Hopefully.
Take care.
Thank you. Cheers now.